Hello, everyone, and good morning. I am Dr. Michelle Darianani, and it is my pleasure to introduce the second session of the 2022 AOCA Annual Convention and Conclave, VAPOR, Education for the Anesthesiologist. We are grateful to be joined by Dr. Rafal Kopanchik and TJ Lockhart. Dr. Kopanchik is an anesthesiologist intensivist at the Ohio State University Wexner Medical Center. Dr. Kopanchik is boarded in anesthesiology, critical care, and critical care echocardiography. Dr. Lockhart is an associate professor of anesthesiology in the College of Medicine at the University of Nebraska Medical Center. He is also a staff pediatric anesthesiologist at Children's Hospital and Medical Center in Omaha, Nebraska. Please join me in welcoming Dr. Kopanchik.
All right. Thank you for the kind introduction. I really appreciate it. So you have to apologize. I have too much energy and I will need to move around a little bit. I can just stand still. So today it is my pleasure to talk to you about my favorite topic, the ultrasonography and point-of-care ultrasonography. And the reason why I like it so much is because it really allows you to do a lot of care right at the bedside and figure out many different things that you think you couldn't think about back in the day, but it makes you really stressed, right? So for a lot of individuals who haven't trained with ultrasound, it always brings a lot of stress. So it's almost like black magic. So today I'm hoping that I will lessen your fears a little bit. And my really big selling point to you is that I really hope you embrace ultrasonography and point-of-care ultrasonography because it is truly the way of the future. And as a testament to that, let me just tell you a quick personal story. I was fortunate enough to work in a Kenyan ICU back in 2016. And to my surprise, when I arrived in the middle of the village in Kenya, there was an ultrasound machine, and the nurse practitioners who were practicing in that particular 6-bed ICU knew how to use ultrasound and knew how to look at the IVC and look at the heart with the basic views. So it is really the way of the future, and I really want you to leave here today believing in the church of ultrasonography, all right? So that is really my biggest selling point to you guys. And with that, I'm also going to talk about topics that are easily understandable in a lecture setting. Most of this work will unfortunately be left to you with simulations, practicing, but there are certain topics that you can actually look at and have a pretty good idea of what to look for when you listen to a lecture. So those will be the main topics that we'll hit on today. And I also hope that I will convince you to then join us today at 3 p.m. for a workshop. There's a POCUS workshop that we are providing for you, and you can still sign up. I think we have 15 spots still available. So if you really like it, if I convinced you, come and join us at 3 p.m., okay? So unfortunately, no conflicts of interest yet, so hopefully after today, maybe. Before we start the talk, let's just talk about terminologies so everybody's on the same page and you guys can follow me a little bit further in the topic. So what is POCUS? So again, point-of-care ultrasonography. And what are you trying to achieve? So it's always goal-directed. There always needs to be a question that you're trying to answer at the patient's bedside. So it's not, oh, here I have an ultrasound, let me go and start looking at things. You always have to have a clinical question that you're trying to answer to provide you with immediate clinical information that you can integrate at the bedside. And you want it to be actionable, okay? So that's one thing that you do need to realize about point-of-care ultrasonography is use at bedside to answer a specific clinical question at a time. And over the years, over the especially last decade, it has really expanded into every field of medicine. So you will see it in the ED, you will see it in the ICU, you will see it in the clinic, okay? But very importantly, it is not a substitute for generalized diagnostics like a true echocardiography that is performed by an ultrasonographer that spends up to an hour looking at the patient's heart, okay? So it's not a substitute, it's just an adjunct. Now, other terms, focus. So this is just a focused cardiac ultrasound. Another term for it is FATE, but according to American Society of Echocardiography, focus is the preferred term. And again, this is to answer a particular question that you might have at bedside with specific views that you can obtain that are previously described. And this is different than a limited transthoracic echocardiography. So this is also a test that you can order that an ultrasonographer will perform with a limited number of images, but it's different than our focus, okay? Other terms, FAST. I think everybody is aware of this one now. This is used by our trauma surgeons to look for either air or free fluid in the belly after a trauma, okay? Then there's also the CCE, a critical care echocardiography. So this is something I use on a daily basis when I'm in the ICU to answer, again, goal-directed questions that I might have about the patient's volume status, for instance. Now let's just quickly turn our attention to the probes that we have available, just so we are, again, on the same page. There are 3 probes that we use for point-of-care ultrasonography. There's the linear probe, curvilinear, and the phased array. So you're trying to come up with a probe that will give you the best images. So the linear probe is very sensitive to shallow structures. So it has very high speed of sound delivery, and with very high speed, it gives you great resolution. So you will see things very well. So that's why we use it for our vascular access, because you will see the carotids, or you can see the nerve with it very well. But it doesn't travel deeply, so linear probe is good for superficial exams. And then as opposed to curvilinear exams, they are lower frequency, and the same with phased array, and you can look a little bit deeper into a patient's anatomy. So curvilinear is great for lung ultrasonography, belly ultrasonography, and then phased array is used in echocardiography because you can actually even focus the view of the actual sound that goes in. So in this talk, we'll talk mostly about all those 3, but mostly about linear and phased array. Personally, I use phased array more than curvilinear because I can, at the same time, look at the heart when I look at the lungs without needing to switch back and forth. And they kind of provide you similar images. And then just a few general terms for echocardiography. You have echogenicity, so how well the sound penetrates the tissue, and relative to the other tissues. If something is hyperechoic, that means that it reflects sound very well. So the structures are going to be very bright because they are reflective. And that's, for example, bone. Then you have structures that don't reflect as much, and that's usually your regular tissue masses or organs with some reflection going back into your transducer. And something that's anechoic, it's just black. So the sound travels through it, but it doesn't reflect any sound back, and that's usually your fluid, air, or blood. And now this is the only physics term that I will share with you today, but it's important to understand this particular one because of the lung ultrasonography. So acoustic impedance. So any medium has this property, and it's pretty much resistant to sound and how the sound travels through it. So any tissue will provide some sort of a resistance to the sound traveling through it. And the ease of how it goes through it is called acoustic impedance. And the reason why it's important, in medicine especially, is certain things will not travel where if the acoustic impedance changes. So if you have a tissue with the high acoustic impedance, and then you have tissue with low acoustic impedance, and if you put sound through it, it will not cross. So think about it this way. Since we're in Arizona, let's say we're in the Grand Canyon. We're standing at the very bottom of the Grand Canyon, and we're going to start shouting. The sound is going to really travel until it hits the rock. But it's not going to further penetrate the rock because the acoustic impedance difference between the air and the rock is so big that all you're going to do is bounce that sound back, and you're going to get echo back to you. So that's similar thing that occurs in your lungs with our pleura. And that's just a little foreshadowing. We're shooting up sound onto the pleura, the difference between the pleura and the lung, the acoustic impedance difference is too great for the sound to travel further, and it bounces back to our transducer, creating a lot of reflection and bright image. So that's just the concept of acoustic impedance for you to really understand what happens with lung ultrasonography. So now let's turn our attention to just some evidence that from other parts of medicine that I wanted to share with you to have you understand why point-of-care ultrasonography became such a big deal. So one study here with trauma improved the exam of a hypotensive trauma patient in the emergency room as very significantly. So those patients received less fluid if they were evaluated with the echocardiography. They spent less time waiting to go into the operating room. They were admitted to the ICU more often instead of going to the OR and had lower mortality. So this one was out of from 2014 and really put POCUS in trauma on the horizon. The only thing I want to mention here, they mentioned that they called it limited transthoracic echocardiogram. So as I already told you, that's not a preferred term. They should have called it FOCUS and not limited transthoracic echocardiography. Also, you can use it during CPR or during code situations. And we all know about pulseless electrical activity. What people have started noticing that if you use an ultrasound and put it on a patient's chest during a pulseless electrical activity, you will actually see the heart moving. So they called it pseudo-pulseless electrical activity. And those patients have higher chance of survival. So this is all beginning research, but those are just the trends that we will see. So during codes in the operating room or in the ICU, you can use it as a guide to tell you if the patient truly has a pulseless electrical activity. One time I personally saw ventricular fibrillation, ventricular fibrillation on the ultrasound where the leads haven't been connected yet, so we knew that we have to shock, for instance. So all those things can be used. A very nice article from last year on diagnostic accuracy, and that shows as well why POCUS is such a big thing, is the sensitivity and specificity of the different findings. So in acute pulmonary edema, you will have 88% sensitivity, 90% specificity. Similar with pneumonia. I would like to focus your attention on pneumothorax because that's one thing that we really want to know quite often in the operating room. The sensitivity with an ultrasound for pneumothorax is above 80% as compared to an X-ray, which is about 40%, 40 to 50%. So it's a great difference. And then specificity for both X-ray and ultrasonography is similar, close to 100%. And obviously, ventricular dysfunction and thoracoabdominal trauma is also very significant. And lastly, POCUS was widely used during COVID era. And these are 9 different areas of exam where the POCUS was useful during the pandemic. But, you know, those were just a few points from everywhere else in the world, but how are we going to use it? So this is a very poor representation of my animating skills. So let's, point of this is that it's going to be a great tool if you learn it. And these are all the different sites on the human body that you can use in the operating room or perioperatively or postoperatively to evaluate the patient. So you can even look through the eye to look at the ICP. We're not going to be talking about that today, but it is a possibility of doing optic sheath diameter to assess ICP. Then obviously we have cardiac for hemodynamics, we have vascular for access and DVTs, we have abdominal evaluation, and then pulmonary and endotracheal. So all of those things are fair game for our use as anesthesiologists. And I do agree with our previous talkers, Dr. Bean especially, who said that we're not technicians, we're not doers, we're physicians. And having this tool in your armamentarium will help you to be a better physician. So today, what I'll try to do is mostly focus on the endotracheal tube placement, ultrasonography, and then some pulmonary evaluation. And then if we have time at the end of the talk, we can talk a little bit about cardiac as well. So can you get trained in it, and is it useful? Yes. So this is a randomized controlled trial of residents who underwent training, and their training was quite significant, with 76% rate of affecting care and 31% of detecting new pathology when the residents were trained over their career as residents. However, there's still a big variability in training, and we have a lot of work to do in the anesthesia world to train our residents and to train ourselves as this comes to fruition. So let's quickly talk about the airway. So these are the different things we can assess preoperatively and intraoperatively. So the new data shows that we can predict a difficult airway. We can then confirm endotracheal placement. We can even predict the size in the PEDS population of the tube that we want to use. We can also ensure that the tube is positioned appropriately and it's not main stemmed. And other cool things is measuring the thickness of the epiglottis if, let's say, a child has epiglottitis. So all those different things you can do as an anesthesiologist if you become facile at a point-of-care ultrasonography. So, difficult airway. This is the newest meta-analysis that just came out in April, assessing different measurements. So at this point, there are 3 common measurements that people do to assess difficulty of the airway. So the distance from the skin to the hyoid, distance from the skin to the epiglottis, and then the distance from the skin to the glottis. So this particular paper combined all the studies and found out that the distance from the skin to the epiglottis is the most useful at this time, with about 10 studies that they found. And they have shown that the positive predictive value is not the greatest, 30 to 50%, but the negative predictive value is in the 90s. So what does that mean to us? If this test is negative, we can feel certain that the airway is going to be not difficult. But if it is positive, then it's kind of a coin flip if it's going to be tough or not. All right, so it's more for negative predictive value than a positive predictive value. And so how do we do it? We take our linear probe or the vascular probe and we put it right above the thyrohyoid membrane and look at the epiglottis. And this is a quick example of that. So the one on top is the distance from the skin to the hyoid. And as you can see, the probe is a little bit angulated up towards the hyoid. Then the next photo is the one with the skin to the epiglottis. So you then lower down the probe a bit and you go directly in and you find this hypoechoic structure and then a very echoic structure, and that's the epiglottis. And then you measure that distance. And then finally, the very bottom one is actually looking at the glottis. So all those 3 measurements you can perform, and you can easily learn, probably even on your own with some time. So then you just measure this distance. So the one on your right is 1.69 centimeters. The one in the middle is 3 centimeters. And then that's just the outline of the epiglottis. So an actual easy enough measurement to perform. So what is the value that we're looking for? And that's where the problem is. There's been many studies, and so far, the distance that's been associated with difficult airway is somewhere between 2 and 2.5 centimeters. Okay? So more studies are needed, and how would I use it in clinical practice? I would start learning it, start measuring it, and if you think that the distance is great, let's say 3 centimeters, just use a video laryngoscope. But again, we have to say this, that the further research still needed, and this should be, at this time, more of a learning opportunity of learning how to ultrasound your airway. And this is just another example of how to perform this particular exam. So now, how do we use ultrasonography for intubation? So I like this study in particular because it created a nice protocol for everybody to follow. And they have shown that main stem intubations were nicely recognized, and only one esophageal intubation occurred and that was also recognized with an ultrasound. But more importantly, I really like the way they designed this protocol. So they would put the probe on the trachea and first examine the placement of the tube, and then they would take a different probe or similar probe and evaluate the lung for sliding to find the mainstem intubation, okay? So a very nice way of looking at our intubation during the induction. So what exactly are you looking for? So A is the airway, and then the big structure next to it, D, is the esophagus. And you should not be able to see esophagus well. So right now, if you see a tube in there, that's called the double trachea sign, because now you have two structures that look similar to one another. And again, usually the esophagus is not easily visible, but if you have a tube in there, it's going to be there, and you will have two structures that look like two tracheas, okay? And that's called double trachea sign. And this is the actual algorithm that they did. So obviously pre-oxygenation, then they looked for the double trachea sign, and after they intubated, they took the probe and evaluated the lungs for sliding or lung pulse. And at the end of that procedure, they did an X-ray to confirm their findings. So I would also suggest you start doing that. Start placing the probe on patient's trachea, see if you visualize the double trachea sign, or sometimes you can actually visualize the tube going into the trachea, and then putting the probes on the lungs to look for sliding and lung pulse, which we will review shortly. But anyway, so this is a nice pictorial representation of a double trachea sign. So the very anechoic, hypoechoic structure in the very middle is the trachea, and then the thing adjacent to it is esophagus with the tube in it. So a very nice representation of that. Then this is a still image of the same concept. You have the trachea, and then you have the esophagus with the tube inside. And this is an action shot of the tube going into the esophagus. You have trachea in the middle, and then an active esophageal intubation. And this is actually a pediatric photo of a tube going into the trachea with the two carotids bouncing around bilaterally. Okay? So how do we size an endotracheal tube? So especially important for pediatric anesthesiologists. You can actually use this in the pediatric population. Again, data isn't great. It's only coming out within the last 5 years, but it's useful to start doing this and learning the actual process. So we place the probe in the around the cricoid area and try to find the cricoid, okay? So in this particular situation, they're just measuring and looking at the tracheal rings. But what is important here is this air mucosal interface. That's the interface that you want to measure. So you don't want to measure the cartilage that's hypoechoic. You actually want to measure the bright structure underneath there, and that's called the air mucosal interface. And then if again, in the pediatric population, there's always, a question: what's the tightest space in airway? Is it the cricoid? Is it the subglottis? At this time, this is the best we have is actually measuring the cricoid cartilage. And again, we measure the air mucosal interface, the distance from that, and then you can decrease your tube size by a half. And certain studies shown that that's beneficial, and the tube is well placed and well positioned this way with the right sizing. So again, jury is probably still out on that, but this is coming, and this is something that you can maybe try evaluating in your own practice and see if this works for you. Now, gastric ultrasound I'm going to leave for our the afternoon session with Dr. Shakal, if you guys do decide to join us for the POCUS ultrasound workshop. very important and very timely with our talks this morning. So now let's talk about the long ultrasonography, which is one of my favorite topics. So for the majority of the history, we did not think that we can actually ultrasound the lung. So this is actually taken out of Harrison's. Ultrasound energy is rapidly dissipated by air. Ultrasound imaging is not useful for the evaluation of pulmonary parenchyma. And as you guys can see, there is a second author over there is Dr. Fauci, the famous Dr. Fauci, or if you're attending the other conference, infamous. Yeah. And this is the guy who proved everybody wrong. Okay, so this guy is a French intensivist, Liechtenstein, who started performing lung ultrasonography during his night shifts in the 90s and really put lung ultrasonography on the horizon. So a lot of the things that we'll be talking about is because of him. So this is where this acoustic impedance comes into play and other physical terms that we need to think about. So a lot of the findings that we find on the lung ultrasound is due to reflections, or also called reverberations. So this is a famous painting by Caravaggio of Narcissus looking at his own reflection here. So reverberation artifact, what is that exactly? There's two kinds. There's the repetition and the comet tail. Repetition basically means that the ultrasound hits a highly reflective surface, or a surface that is at the edge of the difference in acoustic impedance and starts being reflected back to the probe. And then the probe reflects it back, and then it just goes back and forth, with each image going deeper, deeper, and deeper. And then comet tail occurs when sound gets reflected between two air bubbles and a little bit of fluid or water, and then it creates this little divot that you will see here. So foreign body reverberation. So right here on your guys' left, you will see the foreign body being reflected back and forth, and that's called the repetition reverberation artifact, where the distance is the same between the probe and the initial reflection, so where the foreign body is. And then each repetition is equidistant to one another, and equidistant to the initial distance from the probe to the foreign body. And then on the right, you have the little sliver comet tail artifact. However, comet tail is also used in many different settings, so I like to call it a vertical artifact. So from this point on, it's going to be a small vertical artifact and not a comet tail. Okay, so small vertical artifact and reverberation artifact on the left. So how do we examine the lung? There's two ways. You want to look superficially, and then you want to look a bit deeper. So superficial exam is going to examine the pleura. So you want to use the very high frequency probe, which is the linear probe, because it can create a nicely high resolute image. And then for deeper structure, you either use curvilinear or phase array. Again, I usually use phase array because I can at the same time look at the heart and I don't have to be switching back and forth. But, by the book, you should probably use curvilinear for the deeper structure of the lungs, because you can see much more of the field than you can see with the phased array. So, where do we look? So this is the blue protocol that Liechtenstein published in 2008, and this is the protocol that people get tested on, so I figured that's what I'm going to include. So there are 3 points. 2 on the anterior chest and 1 lateral. So you take patient's hand, or if the body size is the same, take your hand and put it right underneath the clavicle. The middle of your palm is going to be point number 1. And then you put your other hand with the thumb over the first hand, and then the middle of the other palm is going to be your point number 2. And then your point number 3 is going to be going directly lateral from the point number 2 all the way back to the posterior axillary line. Okay, so that's point number 3, and that also is called a PLAPS point, which stands for posterior lateral alveolar and or pleural syndrome. So not the best nomenclature, but that's how they called it, because that's where most of your abnormalities in the ICU are going to occur, sitting in the back of your lung that is dependent. So that's why they called it the way they did. But those are the 3 points that you want to evaluate. But obviously, there are other ways of doing it. Other people have evaluated lungs with many more sectors, to the point that you can actually use 20 different sites bilaterally to evaluate something. Obviously, that's not very practical in a fast clinical setting. All right, I guess I'm out of time here. Let me just take a few more minutes here. So characteristic of pleura, shiny and motile, okay? So it looks like ants moving back and forth, And then it also has vertical short artifacts, and it on occasion has a long pulse, which is a vertical motion up and down that corresponds to heart beating. Okay, so these are the characteristics of pleura. Shiny, movable, has on occasion short vertical artifacts, and also on occasion will have long pulse. And this is the pictorial representation. If you put the probe transversely through your chest in that point number 1 or point number 2, you will see 2 ribs on each side, and then a mobile pleura with an occasional vertical artifacts. With, again, here they call it comet tails, we're calling it the vertical artifacts. And then also you can put M mode through that pleura and to see if you have a pneumothorax or not. But anyway, so let's look at some images here. So over here we're putting M mode through our pleura, and what we see is a seashore sign. So we have barcode, 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 or water, and then we have all of a sudden all this shimmering, which looks like sand, hence the seashore sign. And that's a normal lung pleural exam. And this is going to be an example of that. When you have 2 ribs on each side, then the very shiny thing is our pleura, and it's going to move, and on occasion you will see a short vertical artifact. Okay? So let me go back there if we can. Play it over again. Oh, can't I? Can I or not? Or maybe not. Back. There we go. Oh. There we go. Again, very highly movable pleura. And at the very end, if you look at it now, you can see the short vertical artifacts that's stemming from the pleura. Okay, so highly movable, back and forth. And then we can do an M mode. And this is the seashore sign. When you have water on top, sand at the bottom, and that's called seashore sign. On occasion, you can have an irregular border to your pleura, and that can be associated with atelectasis, infarction, infectious consolidation, what have you. In the COVID setting, we actually had subpleural consolidation. So over here, what you will see is an irregular pleural border, and that's called the shred sign. So you will see it right here. So you can see that little divot there. That's a subpleural consolidation right here. So again, subpleural consolidation visible as the pleura moves. And then finally, lung pulse. It's another normal finding. And again, that's just the lung moving up and down with heart rate. Again, this is in a COVID patient that has a lot of lung abnormality, and you will see it pulsating up and down. The vertical displacement is a lung pulse, okay? So why am I telling you all this? Is because lung pulse is associated with mainstem intubation. So if you intubate somebody and you worry that they are mainstem, you can do this exam and look for lung pulse. If you don't see the nice movement back and forth of the lung, but you see vertical displacement, that's called lung pulse, and the lung is there. There's no pneumo, and all you need to do is pull that tube out a little bit. So that's one way of evaluating for a mainstem intubation. And then finally, I apologize for going over, let's just mention the lung parenchyma. So lung parenchyma is not usually visible, and all we're looking at are artifacts. So we are looking at reverberation artifacts. So again, as I mentioned, pleura is highly refractive, and there's a big acoustic impedance difference, and you will have the images being reflected back and forth, creating A-lines. So if you see a lot of A-lines going down your screen when you're using the deeper probe now, so this is where we're going to transition to curvilinear probe, you will observe A-lines. So over here, there it is. We have the pleural line, we have the rib shadow, and you can see that the pleural line gets reflected, and it's getting reflected down, and it's equidistant to the probe and the initial pleural line. And you can see that they're very equally being reflected all the way down to the bottom of the screen. That's normal, that's called an A-line, okay? Now, if the lung loses aeration and there becomes more tissue in the lung than the air, then the lung starts to get fuzzy. So the fuzzier things get, the less air there is. And that's associated with pulmonary edema, consolidations, pneumonias, what have you. Not very specific, but sensitive. So again, as the view is getting more fuzzy, there's less air in the lung. And that's where the B-lines come into place. Okay, so what is a B-line? A B-line is just an artifact that occurs when there's less air and some sort of a fluid that's getting in the lung. And it starts at the pleura and it travels all the way down. And it effaces any A-line. So you cannot identify a B-line if you can see an A-line. Okay, so B-line erases the A-lines. It also moves with the pleura. So as the pleura moves, the B-line moves along with it. You can have up to 3 B-lines for a normal exam. If you have 3 or more, that's abnormal. Okay, and it usually goes all the way down the screen. So let me just show you some images here, and then we'll transition to the next talk. So over here, you will see B-lines, which look like laser-like projections that start at the pleura and travel all the way down and efface any other findings, okay? So laser-like projections. You can see them right here, and multiple. And nice big one at the very end, so you can really see how it looks. So you see here 2 of them now, very hyperechoic, laser-like, going all the way down to the bottom, no A-lines are visible, and they move along with the pleura. Then this is, as the lung gets more fluid, for instance, it becomes more fuzzy. So this is a confluent B-line where it's all just fuzz, okay? So this is progression of the disease as the lung gets heavier and less air is available. And then finally, it can go all the way to the consolidation where you can actually see all the lobes. And this is a COVID patient. So this is one of the sickest ones on ECMO, where you can pretty much see every lobe of the right lung. And this is called hepatization, okay? So this is lung hepatization, and you can pretty much see the whole lung, okay? So for the sake of time, I will go on to our next topic. And again, I really hope that you will take this short tutorial into ultrasonography as a further push to be more facile, start using it, and sign up for any sort of training that you can, either here today or at your institutions or any other certificate programs that are now out there and they're available. Okay, thank you very much, and I apologize for going over time.
Thank you so much, Dr. Kopanchik. I will now turn it over to Dr. Lockhart to begin his lecture on navigating anesthesia emergencies through simulations. Please join me in welcoming Dr. Lockhart.
Thank you. Happy late morning. So medical simulation obviously is a wide-ranging topic. Today I'm going to just kind of talk about one of the slivers of this that is really how to use simulation to navigate emergencies in our learners, and really more specifically, how do we improve team dynamics in the situation. I have no financial relationships to disclose, and really over the next 30 minutes I want to kind of highlight the role that simulation technology can play with our learners, and really how do we integrate different modalities to improve both learning but also even facilitating debriefs, and really discuss some of the strategies that we use to improve interprofessional communication, especially interprofessional communication during critical situations. I'm going to kind of really highlight my role as a course director for an interprofessional communications experience course that I've been helming since 2017 at the University of Nebraska. And really, it's a cross-campus involvement. It's class that is a requirement actually for the senior the senior med students with the College of Medicine. But then we also have senior learners from the College of Nursing and senior learners from College of Pharmacy that join us. And it's their first time pretty much working with people outside of their comfort zone, outside of their typical learning group. And we come together and try to figure out how can we learn from each other. And this is really helmed by the IXL group at the University of Nebraska. And really the IXL group has a mission really to improve performance, effectiveness in healthcare through really adopting high fidelity simulation, interprofessional collaborations, and experiential technologies. I want to really highlight Sarah, Chris, and Austin Brake, who have been instrumental with the process and have been kind of the key drivers to make this successful year after year. Why cardiac arrest? Obviously, it's a big topic also, similar to simulation, but really, I like it because it's a curriculum that is apparent in all healthcare professional training. Learners are really confident in their specialized training, but they have minimal experience really doing the interdisciplinary team dynamics, really in a high-pressure situation. We're very much all in our silos. We know what we're supposed to do. We're confident following our algorithms, but we're really at this stage in our learning not confident being a team leader, not confident interacting with others, and really not confident in these critical environments that are really time-sensitive. The intermingling of various professionals during a response to a medical emergency is very ideal for professional and interprofessional skill building. Cardiac arrest also allows for assessment. Multiple sessions obviously allow for further reflection, further improvement. We can repeat and do again. And the hope and the goal is really moving from an individual to a team focus. You can focus on your assessment on medical knowledge. You can focus on team dynamics. You can focus on team safety, communication skills, like as we are with this. And really getting feedback. The immediate feedback is really what's necessary that helps with driving this learning situation and is essential for these to be successful. So overall goal really is, what I tell the learners is to be confident with your teamwork as you are with your clinical skills at this stage in your training. Because if you look at sentinel events that have happened both at our institution, hospitals across the nation, you do a root cause analysis and you boil it down to what are some common factors. Poor communication, really a lack of teamwork overall are common themes. And if we can do anything to improve these areas, it's not only beneficial for us, but also for our patients. So how does this look? So this is kind of the simulation structure that I use, and it starts with a pre-brief, and this is where I kind of set expectations. I want everyone to know that the goal of this is to have fun. No one should be on the spot with this. This is meant to be an educational process where no one gets hurt in the process, except maybe their egos. But then we move on after the pre-brief, we do a simulation. And this oftentimes it's kind of the fun part of the day, where they can experience high fidelity simulation for the first time. We then follow this with a debrief for the learning opportunity, and then kind of see what we can do better and repeat the process with maybe a few tweaks, and then debrief again. And again, the highlight is the debriefing is where the learning is occurring. So what happens in this pre-brief? Really, I speak of the objectives that I want them to get out of the session. So really understanding the importance of team communication in a simulated code environment. How do we use methods to improve information exchange, using call-out, using closed-loop communication that we all know is working well. How to be mutually respectful and offer task assistance in a team setting. This often, they have had minimal training on this in the process. And then really kind of wondering what duties as an individual can I bring to the team to be more effective and better in this cardiac resuscitation method. So we highlight the effective team dynamics. These are the 8 areas that the American Heart Association really focuses their training on creating an effective team. And so before the sessions, I have everyone watch an online video that really is pretty much the AHA's mega code. And it lets them kind of see how an ideal team that we would love to see happen in a real life code, how do they interact with each other. So we talk closely about using closed-loop communication and sending clear messages, but then I really stress the importance of you really need to make sure these roles are filled and you know what your responsibilities are in the code, especially when it's first starting up. But then also knowing your limitations and realizing, as we are in our silos, everybody's coming into the code with different mind frames. They might see something that we're not seeing. And so how do you share your knowledge and intervene in a constructive manner to make the code more effective and also be mutually respectful to everyone in the same process? So in specifically looking at some of the communication methods, these are from Team Steps, which is a governmental program that's goal is to improve healthcare communication. And really the whole goal of this is to allow team members to simultaneously get critical information to other members in the next steps, being able to know exactly who the communication is designed for, and so then hopefully they can anticipate what's coming also. Oftentimes, we might be, this in a commonplace, we might know a level 1 trauma coming in, so we're all down in the trauma bay. We've had plenty of time for roles to be established. As the anesthesiologist responding, I know that I'm at the airway, so when the team leader asks when the patient comes in and we're doing our primary survey, going through the ABCs of the primary survey, when the team leader says, hey, what's the airway status? I know that the team leader is talking to me, so I can say airway is good. So we move on to B, breath sounds. Breath sounds are decreased on the right. The entire team knows before we move on to C, circulation, we better figure out why our breath sounds decreased on the right. So this is great when you have those roles established ahead of time. Is that as realistic as possible? No. Oftentimes with codes happening, you're in this kind of beginning phase where everybody's trying to figure out who's who, what's going on with the patient. And so there's always the possibility that the tendency is people will ask in the beginning phase, can someone do this? Can someone do that? And I stress to them that that is not effective communication, because what happens is you might have one person doing something. Can someone get me a EKG? Can someone get the blood pressure cuff on the patient? Either multiple people are doing it or no one's doing it. It's hard to direct your communication. So we talk about simple things as looking at somebody, pointing at them, put the EKG on the patient, or using their title or role. Anesthesia, prepare to intubate this patient. Pharmacy, drop 1 milligram of epi. That way we're directing communication to each other and not just using, can someone do this, can someone do that? So we practice doing that during our simulation, and then also using check back, or really this is closed loop communication. We all know the value of closed loop communication to avoid the telephone game from happening in the first place. I really like to stress that it's important to use closed loop when specifically asking for like drug dosing to be used. So I might say pharmacy, draw up 1 milligram of epi. The pharmacist will drop 1 milligram of epi saying, drawing up 1 milligram epi IV. They hand it off to the nurse. The nurse then says, flushing 1 milligram of epi IV to the patient. The recorder can mark it down. 3 to 5 minutes later, they can let us know it's time for another dose. The team can move on. We've avoided any errors, hopefully, by speaking out loud and double checking what's going on. And I stress that this, again, is an important method for being able to convey information in a stressful situation. So, as I mentioned, not everybody in their silo is ACLS trained that comes to our groups. So we have the med students that have all had ACLS before, so they're kind of more familiar with this chart that we're showing. But the nursing students and the pharmacy students have had BLS training, so it's not, I kind of do a little mini review of what ACLS, what's a shockable rhythm, what's not a shockable rhythm. I think it's a good review because I highlight the importance that you should be using these algorithms at this stage in your training because they are meant to help you. If you're going to be more familiar with what to tell someone, you're going to be more confident in the decision process. So we go over VFib, VTAC as shockable rhythms, asystole, PEA as not shockable, and then move on to the next phase, which is the simulation. And again, this is where I stress, no one should feel on the spot. We do have one of the med students be the team leader in the process for the first go around, so they will be set up as planning for that. And then the nursing students and the pharmacy students will comprise other parts of the code team. Really, the simulation structure at the University of Nebraska, we're very fortunate to have this really fantastic learning space across our campus. This is a picture of the Davis Global Center, which opened in 2020 for $121 million and then 192,000 square feet of learning space for us. It kind of supplements and integrated a lot of the common simulation areas across campus into one zone. What is high fidelity simulation? Obviously, not everybody here probably knows what high fidelity simulation is. I'm assuming a lot of you do know. But really, they are lifelike mannequins designed to react physiologically as if they're like a real life patient. So you can see in the bottom picture here, this is a mannequin that is being used. It can talk, blink, breathe. You can listen to heart sounds, lung sounds, bowel sounds. Really, you can perform clinical skills on the mannequins, and we as the sim team can then make things better or worse based on your interactions with the mannequin. Really, in a nutshell, they can do anything except really get off the bed and move around. The bottom picture then here shows one of our COVID training sessions. So you can kind of see the high fidelity mannequin. You have all of the pretty much the supplies that you would have in real life along with you. And really the goal is to make things as realistic as possible, because if you don't have realism, they're not going to get immersed in the simulated clinical environment, and it's not going to be as effective of a learning tool. So you can see this top picture here is one of the PICU areas as part of our, in the Sim Center. So you can see our code cart. We have obviously the nice cartoons on the wall to make it a little bit more pediatric friendly, but all of the rooms then are designed to be similar. You have the integrated video recording system in the ceiling. You have pretty much a wall of working gas and everything on the wall, and a lifelike bed, a lifelike mannequin, and then we have the video wall, or the mirror wall that we can stand behind, so then they're not seeing us as we're adjusting things to be able to interact as they interact with the patient. Standardized patients also, I'm sure we're familiar with, but they're individuals really that are trained and they're meant to act as patients, family members, medical professionals in a simulation. SPs help learners practice physical exams, history taking, having difficult conversations, gathering information on an unresponsive patient. And really, we like them because you can also teach them to help with skills that are important for teamwork, leadership, communication, empathy. That's a big one that I feel like some of the learners are not getting, so teaching them to be empathetic. And really, when an advanced learners benefit when you have multimodal simulations. And what that is where SPs and our high-fidelity mannequins come together in the same scenario and create an even greater effect with the learning opportunity. So the next few slides are video clips, and we're going to kind of show an idea of what we do during these simulations. So we have our high-fidelity mannequin that is in the top left here, and his name is Carl. He's 54.
Christian Doolittle headed to AOCA.
Take a listen to you here.
Alright. You might get my tummy grappling.
Yeah.
Hey, Carl, do you know where you're at right now?
In the hospital.
Okay. You know the date?
So that was Carl. So how the groups are interacting is that they are a group of 8 individuals. So we have 4 med students. They're associated also with the 2 pharmacy students and 2 nursing students. So I pretty much tell the pharmacy students, nursing students, med students, you guys are part of the code team. You're going to go in, get this information regarding the patient. They start with a nursing assessment with the 2 nursing teams, and then that you saw in that video that was their interaction with Carl. And they're really told that he came in with chest pain in the ER. He was treated. This was the first time it happened. He was given nitro. He was given aspirin. He had a negative EKG, negative troponins. He was sent up to the floor for further monitoring, and that's when they were going to be interacting with him. So the nurses are interacting with him there, and then the next part is they're going to witness a code event happening. And so we kind of can see how they interact with that.
Yeah. Okay.
Carl,
Carl!
Defib arrest.
do you want to pull the bed down off the wall?
Yep.
Pull yours?
Yep. Yep.
The code button was hit. The code key is called.
Starting compressions.
Alrighty.
Do you want to
Where's the empty thing? Yep,
Hold
you
it.
can get it that way.
break and pull the bed down?
Alright, guys. Alright, so we got Carl. He's a 50-year-old male. He came in yesterday about 1 a.m. for chest pain. It's his first experience. We gave him nitro and morphine. He's got 100 of LR running to gravity right now.
Gold, you guys do airway.
He'll start compressing.
So you can kind of see with this interaction is then we have the opportunity then to use this video system capture system that we're using is through CAE. It's a learning space, but what's great about it is you can have different angles of the room, and then we have a picture of the actual monitor for the vitals, so we know as things have changed how the group interacts. What is capable of happening during the debriefing phase of this then is we can kind of even measure things such as time for compressions to start. We can give feedback on that and see if it can be improved. But what I like to specifically debrief with the group during this time is how did the communication that the nurses knew get expressed to the rest of the team? Did everybody feel like they were able to interact and get all the information that was needed? And so after the simulation, obviously comes the debrief. And this is after 2 rounds of epi, 2 defib attempts. That's when we typically, unless they really mess up, have Carl come back to normal sinus rhythm. And then we kind of have them discuss what the next phase in his care is going to be. And then we stop the simulation and go into another room and do a debrief. Learning is really dependent on the integration of experience and reflection, and really the evidence is extremely clear that essential learning occurs in the debriefing phase of these simulation-based experiences. And really what we want to do with the debrief is use that AV recording system, have the patients or the students watch themselves, which they love to watch themselves, and see kind of how their perception of the event is different than actually what has happened. And then also use these open-ended questions to kind of just help further discuss how things went. Was communication clear? Did we see any closed loop communication happening? Did you see check back happening? Was situation awareness maintained? Did everybody have a role? Were all the roles filled? What errors were made? What could be improved? And really this debriefing promotes the understanding and really supports the transfer of knowledge, skills, attitudes, and there's a focus then on how to promote safety, how to promote quality care, and really how to develop the patient, the learner's professional role. So then we sim again. So hopefully the learners can take what went well, what didn't go well. We have them actually change who's going to be the team leader this time around, and we sim again. And this time, though, we introduce a standardized patient that they had no idea was involved. So with this video, in 1 second, we'll show that Sandra, who's she plays the role of the wife of Carl, and she went away for coffee and comes back and sees that this is happening to her loved one. So she's pretty much told to stay in the room, be shocked, obviously, by the events, and just kind of go with the flow of the group and ask questions to try to distract their communication to see if they use any of these skills to improve that. So we can play the video.
Joel, he's he'll start compressions first round. He had.
What are you doing to my husband? What's going on here? Carl?
Ma'am?
What happened?
Ma'am?
I just went for a cup of coffee and...
Ma'am, can we actually have you leave the room right now?
No, I'm
we'll
not
keep you
leaving.
updated.
No, I'm not leaving the room.
Here, you can watch from the corner.
What?
We just need him.
What is...
We gotta take care of him, dear.
Tell me what's going on. No, I'm going to stay right here. I'm going to stay. I know, I'm going to stay right here. Okay?
We can better care for your husband if you have a
I will stand back, but I'm going to stay here so I can see what's going on. But what happened? I just went for a cup of coffee.
The addition of Sandra kind of acts to shock the group mostly. There's a wide variety of experiences of how they interact with her, to calling security and having her physically pushed out of the room, to others that are more empathetic and realize that she is seeing her loved one and getting his chest pushed on, and they can use her then to get information regarding Carl. But it's very, very wide-ranging. You can definitely hear pretty much everything stop, and then they realize they need to keep going on with the procedure. But you see the addition of just one extra player in the situation causes more chaos, more confusion, makes it much more realistic, much more lifelike to pretty much how most codes will happen in the hospital system. So we also then have her want to ask some difficult questions to the team. So we can play this video.
I'm just gonna trying to sit back a little, okay?
Switch?
Yeah, switch.
We're doing the best we can right now. Okay?
Well, I realize that, but it's also my husband.
Yeah,
I
100%. You can go ahead and give that reference.
understand. So should I call
Is
his
there any
kids?
concern?
Should I call
Do
his
they
kids?
live close?
No, they don't. They live an hour away.
Well, we can, if you want to, he is, I would, yes. You
And
can
what
call
would
him
I
if you
tell?
want to.
What would I tell them?
You can tell him he's having, he's.
Should I call his kids? Is he going to die? These are questions that they're in real life are going to be faced with, and this is oftentimes their first time thinking about how would they interact and how would they ask these questions. And similar to the first session, after 2 defib attempts, we do get Carl back to normal sinus rhythm, and then this is where I kind of have them hopefully try to summarize what's going on and hopefully show a little bit of empathy in the process. So we'll watch this video of how they interact with her.
Okay.
Got a pulse?
Okay.
Right
That looks kind of like a
And
STEMI.
STEMI?
Yeah. Do we have a
Do you want a cardio break?
Okay.
Well, no, man. I want to be helpful.
All right, we'll be getting 12 lead.
The
Is he
most
responding
helpful
up there
thing
at all,
right now
Joel?
for us
Carl.
would be if
Carl.
you can sit and watch.
Can you open your eyes, Carl?
Do we need a cardio
Not
break?
responding.
Carl?
He's got
Carl?
STEMI,
I got
so
a
the
pulse.
cardio vert won't do
Carl?
anything.
Carl, can you hear me?
Everyone's being so loud.
Yeah, I know, but it is loud. All right.
Carl, I just went for a cup of coffee. What happened?
We're gonna need to call down for the cath lab. Ma'am,
Yes,
I'm
Carl.
sorry, Carl. Your husband seems to be having a heart attack. He went into cardiac arrest. He is back now, but unfortunately, he's still having a blockage, which is showing on our monitors. We're going to have to.
And so I think the most important part of this entire simulation structure is now when we do this repeat of the debrief, and this time we were able to debrief with the standardized patient also involved, because then she's offering the feedback of the role she just played in the simulation. As a trained professional, she's able to evaluate the learner's specific and observable behaviors and focus really on the communication and empathy skills, how she felt with them, and using heart and logic statements so then no one's really feeling on their spot, so they're hopefully then leaving this experience with a positive experience. And really, hopefully, her goal is to encourage really a collaborative debrief and just kind of really guide the self-reflection using those same open-ended questions that we used before. And really, by incorporating simulation capture along with the audiovisual playback, the learners are able to see how likely what they remember of the situation is different than what is perceived by the video. And really, the role of the family member and the ability to try to teach empathy and show empathy, I think is something that is definitely a needed aspect in today's learning environment. Successes of the group, challenges of the group. So over the years, there's been noted successes, noted challenges. Many of the learners, I see it's a huge benefit because it shows them the world of simulation and shows one of the little slivers that can be done, and having this as an educational tool for them to use. Overall, there's been positive feedback from the group, and it's really rewarding to see someone that's later on down in training that went through this situation, maybe in pre-COVID, that was able to kind of come back and give experience and say, hey, this really helped me be able to actually take care of this real-life COVID patient that was a really stressful time. I think the key thing is maintaining that this is meant to be fun, and no one should be on the spot with it. I think it helps to have them all have a little bit more relaxed stance in the process. Problems, challenges, COVID-19, obviously you can't Zoom a simulation, so it's kind of dealing with smaller groups, having to have more spacing, having to hire a new standardized patient every round, and so it made it difficult to get all 140 plus students through in a timely fashion. But again, it continues to hopefully show that this is one of the small ways that you can use simulation to kind of help highlight the role of simulation in anesthesia education, and really hopefully show you that you can use simulation to improve learning, facilitate debriefs, and we are the key drivers for considering our unique role in the operating room in our hospital system, and I really encourage you to try to promote simulation experiences at your home institution. Some references, but I will be able to answer questions.
Thank you, Dr. Lockhart. And we will now begin our Q&A portion and discussion. If you have a question for Dr. Kapanchik or Dr. Lockhart, please come up to one of the floor microphones here.
Dr. Kapanchik. Great talk. This gets asked of me frequently, and I don't have a great answer for it. The concept of ALARA, or as low as reasonably allowable, for medical testing, for instance, commonly applied in like radiology. We ultrasound everything and do it a lot. Do you think we have a good grasp on safety with doing things like that? At least patient safety directly attributable to ultrasound?
100%, and that's a great question. I totally agree with you. I can just see it with my own skill. I really hold down my ultrasound skills, especially the lung ultrasonography with the COVID pandemic, because I was ultrasounding lots of patients. And I thought that I was pretty facile with it until I started doing it, day in and day out, and really recognized how better my skills have gotten. So I truly agree that we need to have a minimal number, especially for critical care physicians and anesthesiologists, just like we have with any other procedure that we do or any other tests that we learn. I think there needs to be research to see how long and how many exams you have to perform. Like I would have to say probably at least 20 to 25 for lung ultrasonography, probably similar for gastric ultrasonography, and then when it comes to assessment of the cardiac function, it's probably even more than that. And that's really exemplified by the NBE, who now certifies intensivists in cardiac or just critical care ultrasonography. And for that particular certification, you need 150 exams of just cardiac. So I think, as anesthesiologists that practice in general setting, that might be too much. But for cardiac, I'd at least have to say 50. But yes, we need to have some sort of a governing body that would be responsible for oversight of the quality of the exams that we perform. And it's like anything else that we do.
Thank you.
I have a question for Dr. Lockhart. How do we initiate a simulation education in a hospital that has not done this before?
Well, I think the great thing about simulation is you don't have to have $1 million sim center to be able to do it. You can, oftentimes when we're doing them on the fly at our children's hospital, we don't have a dedicated sim center, so you just invest in some of the equipment, task trainers, high fidelity simulators. They can range in price, but you can just use your general OR that you're typically normally in, so you have all the equipment there, so you're very familiar with the processes with that too. So there's different ranges based on how much you want to invest, but I think the concern with that method is obviously there can be wear and tear on some of the mannequins, wear and tear on some of the materials, so having a dedicated sim space I think overall is more ideal.
Okay, thank you. Dr. Kopanchik, I have a question for you. Can you go over actually how you would incorporate the use of POCUS? Let's say you are covering the PACU and the nurse called you to evaluate an elderly patient with a history of end-stage renal disease and cardiac stent, and he is now hypoxic.
Yes, it's a great question. So first, you do need to be aware of the ultrasound tools that you have available. So make sure that before you start practicing it, get yourself familiarized with the actual ultrasound machine that you have and see what probes you have available. A lot of times we still only have the vascular probe in the perioperative setting without the other probes like the curvilinear or the phased array. So talking to your regional colleagues and see what is available at your institution is of definitely great importance. And then when it comes to patient evaluation, again, you started with a very good premise. So there is an actual clinical question, right? So we have a goal-directed exam that we can perform in this particular situation. So our clinical question would be hypoxemia after surgery. So we can, think of all the different differential diagnosis being end-stage renal disease. When was the patient dialyzed? Are they volume overloaded? How much volume did the patient get in the operating room? Do they have cardiac history? All those things we need to ask ourselves before we start looking at the patient. So at that particular point, once I do know a little bit more about this particular situation, I would start with the lung exam. So primary question is hypoxemia. Let's take a look at the lungs and see what we see. So in this particular situation, I will be looking mostly for A lines versus B lines, right? So again, we're most likely assuming that the patient is going to be likely volume overloaded. So we're going to take the deeper probe, the curvilinear or phased array, and look at the lung parenchyma. Do we see B lines? Do we see B lines bilaterally? Do we have A lines, and then do we have an actual mobility of the pleura? We can't ever forget about the rare instances of actually developing pneumothorax, but that's another way we can evaluate this patient for looking at the pleura from pleural shimmering and then doing the M mode through the actual lung tissue to look for the seashore sign versus the barcode sign. So that's how I evaluate the lung. If we see very heavy B lines or confluent B lines bilaterally, we can potentially say, oh, hey, this might be volume overload. And then, but that's not always the case, right? So then we have to look at the heart and see if the heart is getting volume overloaded. So if you're more facile, you can answer questions like left atrial pressure. Is the left atrial pressure elevated? You can look at the IVC and see if the IVC is very plump, which will also go with the fluid overload. We can also look at the actual ventricular function, the valvular function. All those things can help you answer that particular question.
Hi, Jess Giller, Omaha. I have a question for Dr. Lockhart. Have you had students that have been able to take advantage of the simulation program return to you after and describe in real life situations where they were able to draw upon those experiences and that they felt they were more comfortable because of having gone through that simulation experience?
Yes, and I think the one that comes to mind is a resident that went through the training earlier and is now in PEDS and had their first code, and the mom was in the room during the code, and we all know that is an extremely stressful situation, but she credited the fact of being able to practice the skill in a simulated environment, and it made it much more. I don't know the word of that she mentioned, but she just felt more familiar and comfortable with the situation and knew that it was the right thing for her to have her present in the room too. So we see that a lot with PEDS. Obviously, on the adult side, it's not as common, especially what these current learners have been experiencing with codes in the hospital is we've been doing COVID codes, and so they don't have loved ones around, and so it's a much more kind of sterile environment, and they don't have this interaction with other family members, and it's kind of a loss for them with the education right now, is that they're not getting to see how their actions interact with family members, interact with the patient, because they just haven't had family members around. So
thank you. I have a question for Dr. Kompanchik also. Have you seen the usage of point-of-care ultrasound for an intraoperative concern for something like intraoperative pneumothorax? An example being, historically I had a case where we were doing a Nissen fundoplication in a small patient, and when there was decreased breath sounds and desaturation abruptly, obviously you go through all the normal checks, and the next step would be to ascertain through x-ray whether you're able to see a pneumothorax, but it's in obviously the supine position. Have you seen the possibility of utilizing the lung point-of-care ultrasound to facilitate or potentially even replace in order to be able to act more rapidly in that type of a scenario?
Yes, that is actually a perfect situation for the ultrasound, and that's been relatively well described. Thankfully, I haven't had to do it yet, but you can definitely do that. So the way you would approach that particular situation is this way. Take your surface ultrasound or your vascular ultrasound and put it at the anterior portions of your lung in those 2 points that I showed you guys. And look for the pleural shimmering and pleural mobility and the lung pulse. If you see any of these things, the actual chance of pneumothorax is unlikely. So the best way to think of a pneumothorax is lack of normal findings. So if you have a pleural sliding, lung pulse, or short vertical artifacts, there is no pneumothorax at that particular point that you're evaluating. So again, that's actually very important to remember. Lung pulse, lung sliding, so lung pulse, lung sliding are the very important parts of this particular exam. And then make sure you go to the lateral sections as well, because sometimes the pneumothorax can occur a little bit more laterally. So examine every component of the lung from those 3 points that I've mentioned. So again, using the same surface probe, look for these findings. And if you see then you're fine. Additionally, if you have difficulty identifying those findings, use the M-mode ultrasonography. So put the M-mode through that rib space and look for the barcode sign versus seashore sign. So seashore sign is the barcode on top and then sand at the bottom, and barcode is just barcode everywhere, and that's more or less more consistent with the pneumothorax. But you do have to be careful because let's say you have a patient who has COPD. They can have blebs. You can just be looking at the bleb, and the bleb will have findings that are consistent with the pneumothorax on the ultrasonography. So you do have to also remember the patient that you're dealing with. And again, you have to evaluate the lung in many different sites. So don't just look at one area on top without evaluating a little bit further down. There are also other findings that are a little bit more involved. Another common sign described is a lung point, where you actually see lung moving in and out of the pneumothorax field. It's a bit more involved, more difficult to find, but it's also been described, and you can get tested on that. Long story short, you do want to look for lung sliding, the shimmering of the pleura, short vertical artifacts, and lung pulse. If you identify any of those findings, there was an actual lung tissue there and no pneumothorax.
Thank you.
Actually. So how do you think, or how do you recommend that we go to our institutions or our hospital systems and demonstrate value for POCUS and the use of simulation in education?
I think that's an extremely difficult subject, especially in our current world of not having really the clinical time, or being more clinically needed and not really having the time to do some of these things. And I know that's a common short staffing situation at many institutions around the country. But I think it's just continuing to get buy-in, and not necessarily just from anesthesia, but buy-in from perioperative services. We commonly will be doing simulations now with perioperative nursing and just showing how going through even these zebra type of situations, such as malignant hyperthermia, is an important thing to just always continue to keep in the back of our mind, keep us refreshed. And so I think you just have to, I just keep nagging, and I think you just have to be that squeaky wheel.
From the POCUS side of things, I really think you need to engage multiple stakeholders. So who else is doing ultrasonography at your institution? So you have radiologists, you have cardiologists, and you really have to approach this with a multidisciplinary fashion when you talk to your friends from radiology and cardiology and have them also vouch for you, because a lot of times there is some turf wars. But if you play your cards right, you can make the argument that, hey, you know, we're really loosening up a lot of the staff that they have to go and do other tests that they might be doing on the floor, like an actual full echocardiogram or other tests that they might do, and you can actually apply it right there and then. So that's going to be one way of actually save some dollars for your institution if you talk with your other colleagues who will be there for you and support you in those decisions. Additional thing is, like, you're pretty much shortening the time of care. So let's say you did have that situation of potential pneumothorax. Now you have to stop the surgery, call in the x-ray, put the plate underneath, and that's going to prolong the surgery time. You're going to be in the operating room for longer. There might be some add-on cases you want to do. This is just a quicker way of evaluating for the abnormality, and the life can go on if you have your question answered in a timely fashion. So that's going to save a lot of time and money as well. So I think there's a lot of different ways of going about it. You do have to use or talk to all the stakeholders who are interested in this particular modality, and I think it's doable.
Thank you.
Sorry to ask so many questions. The tie-in, dovetail in there is, can you charge for point-of-care ultrasound? And if you can, like we in the pediatric hospital get leveraged all the time to go and help with IVs outside of the OR when you have a whole vascular access team and et cetera. So we turned that into a billing, you're taking your expertise, you're using it, we have an ad hoc procedure and we're able to bill for it. Are you able to do the same thing and leverage that as a value analysis for why to increase the ultrasound presence for the same reason?
Yes, 100%. With the caveat that it's actually very difficult because a lot of centers that still do point-of-care ultrasonography have a really difficult time of creating the infrastructure that is needed to bill. So obviously you have to have storage of the images. Then you have to write a report, and then you also have to get credentialed by your institution, and then finally be able to bill it. For a lot of institutions, including mine, that's a very big hurdle. So it's definitely doable. And again, that will also answer the question of utility for making some extra money for the institution that you work with, but it does require a champion, in all honesty. You need to have somebody or a group of champions who are really committed to get this up and running, because there's a lot of hurdles to go through.
Yeah, I agree with Dr. Panchik. There is some hurdles because it depends on your institution. Some institutions have specific contracts to the radiology department that will not allow any others to use ultrasound or to bill, so you have to find those things out.
Yeah, that's a really common problem. At the institutions where people still think about the 20th century, they really block your usage of the ultrasonography. But I think if you present it in a good fashion, I think they will become believers as well, because it really frees up a lot of their manpower, in all honesty.
I was just going to add a comment on that. For those of us not in academia, check with your billing company. And different billing companies are going to require documentation based off of what they'll code it as. For our situation in a private practice, intraoperatively, we could not have the attending anesthesiologist bill for intraoperative ultrasound outside of cardiac and doing a TEE. But let's say it was a general surgery case, your example, Dr. Goggins. We would have to have another anesthesiologist come in to do it because they're not the anesthesiologist of record. And then it's sort of like intraoperative. If we're doing a bronch, we can't bill for a bronch while a surgeon can. There's those particular billing hurdles. Anyone can do it, but I just wanted to comment on that.
Okay, thank you everyone for your questions. We are at time and we'll need to conclude this session. Please join me in thanking Drs. Kopanchik and Lockhart. And there is lunch, and we can meet back here for abstracts and poster sessions.
Thanks, everybody. Just want to remind you that poster presentations will be in here, so feel free to bring your lunch back and participate in that as well. Eat in here would be fine. Thanks.
Thanks, guys. You guys did good.